Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. We've got a really interesting show today I've been looking forward to for some time. My guest today is Dr. Mark Massing. He received his BS in computer science at Florida Atlantic University, earned a MS in public health from UNC-Chapel Hill, MD from Duke University, and a PhD in epidemiology at UNC-Chapel Hill. The boy's got some learning. So, Mark, thanks for joining me on this episode of the Tate Chronicles.
Well, thank you, Jim. It's a great honor to be here.
As I said, I've been looking forward to this conversation with you because so many of the things I've talked about in the Tate Chronicles has to do with the benefits of health information technology. But we're going to diverge a little bit from the usual analysis of that potential benefits of technology for healthcare, because technology is not always a silver bullet. I want to talk with you today, Mark, about some of the things that technology can't do, and particularly what societal issues, unless they are changed in some or mediated in some way, really throw a roadblock in our quest for healthcare improvement, especially among marginalized communities. So, Mark, let's first take a look over our shoulder at the COVID pandemic. Okay. The technology gave us immunizations, but there were some groups who were more impacted than other groups. Tell us a little bit about your thoughts on that.
Oh, that's absolutely true, Jim. As almost all healthcare providers know, not all people experience health and healthcare in the same way, and especially folks that we often call the historically marginalized populations. That is, people who have high healthcare risks or high health risks, what due to their low income or low education, or living in relatively deprived neighborhoods, and et cetera. There are several populations that are well defined that we know that typically have higher rates of adverse health and health conditions. And COVID was a great example of how our economic systems actually play out directly to have an impact on health. In the case of COVID, we know that populations that are living in low-income areas, people of color, people that were, because of labor conditions, were working in industries where they were forced to be in public. All of these folks were at high risk, and they were the folks that actually had high risks of death as well. And that's well documented in the literature.
You know, one thing I'd forgotten about till you just mentioned it, when COVID was starting to really ramp up, certain groups of people were, based on their jobs, were identified as, I think the term was, essential workers. And,
yes.
and those essential workers were often people who were in the service industry. Right. And so just from the get-go there, not even talking about access to healthcare, that issue I totally forgotten about. But you're right. Those service industries that were identified as what you people got to get out there and get more exposure.
That's correct. And of course, your definition of essential might vary with respect to your perspective. For example, I know that people working in the meat producing, meat packing industry were classified as essential workers. Here in North Carolina, where I live, many of those folks were at high risk for COVID and developed the COVID epidemics right within the packing plants where they worked. Whether you would define that as essential or not is, well, it's sort of like from your point of view, where you stand in the
Mhm.
economy and who benefits and who loses. Sure can.
Okay, good. Well, and so definitely in terms of COVID,
Uh,
those marginalized population face greater risk. They also had less access to care and higher death rates. So it was really across the board that we saw that. And just because the system may have really good health information technology and interoperability, it did not touch those issues at all.
that's correct. If I can give you just a little perspective,
Sure.
I certainly am not agnostic about the use of electronic systems or data because I do have background in computer science and epidemiology. So definitely data is something that I'm very familiar with, the strengths and limitations. But working with physicians quite a bit, I always find that there is a tendency for us to move into deeper and deeper data and start forgetting just how much we already know about the patients and the communities they come from. And there's a lot of information that we're just not really acting upon. So you could ask the question, to what extent do I actually need more data to be an effective healthcare provider? Perhaps what I need to do is start thinking about how I can act on the data that we already have.
There's also an issue here about the trust of the healthcare system itself.
Mhm.
We still, I guess it's almost in the background memory or deep memory of a lot of folks, such things as the Tuskegee research trials, where groups of marginalized people were with syphilis, I believe in Alabama, were not treated to see what would happen.
Right.
And so, if that is part of cultural history, people think, well, should we even trust the healthcare providers or the healthcare system at large?
That's absolutely correct. I do hear Tuskegee is brought up almost all the time when
Really?
touching on this subject, and it's certainly an important, in tragic application of science in many ways. However, as we all know, now there's getting to be increasing mistrust for expertise in general. A lot of it is based upon misinformation that's being received. It's very difficult for any of us to be able to trust information, no matter what source it comes from. I will say I saw a recent survey from Yale. They have an organization there based up or that investigates climate change communications. They did a survey during the COVID-19 pandemic to identify who were the trusted sources in the
Mm,
general public,
hmm.
and the physicians turned out to be at the top of the list among the most trusted sources of information for COVID. So I think that's a real strength for physicians. We're still trusted, maybe not as much as we used to be in some ways, but I think there's a lot of trust, and that's an opportunity for us to use that trust in order to make a difference in the health of the communities of patients that we serve.
Speaking again, Mark, about marginalized communities. So it's not only maybe a lack of trust of the healthcare system, but also certainly what we saw during COVID-19, uh, essential workers, less access to health care, higher death rates. But there's also such things as you touched on climate issues, but even geographical issues related to where communities may locate their industry or waste dumps. They're not.
Yes,
They're going to be located near marginalized communities, and
yes,
so it's not only uh, an unequal bearing of the burden for a lot of reasons. It's almost an assault on those marginalized communities.
absolutely. It's just the overall concept, I think, is the concept of justice. There's there's climate justice, which is and environmental justice, which are areas
Hmm.
you just spoken about. Certainly during the pandemic, we saw injustices related to social and economic inequalities. And so we have a balance that we're always trying to achieve in terms of defining what is just and trying to ensure that all groups have some equality in terms of their access to health and healthcare. For example,
Hmm.
the COVID-19 pandemic, I've been that was something that we were all focused on for 2 or 3 years. But now that it's waning quite a bit, it gives me a chance to return to the climate change area, which is something that's really central to my work. But during COVID, I saw many parallels between what was happening in that pandemic and the same challenges that we face with climate change. For example, uh, we know that there's disproportionate risks and impacts in historically marginalized populations, which I already spoke of. We saw that people in those populations were at high risk for COVID, but they're also at high risk for the impacts of climate change. But at the same time, the power that those folks have is relatively low compared to the people who benefit the most from climate change. People who are involved in generating lots of greenhouse gas emissions, for example, those are typically the high income people. And people who are lower income or marginalized populations who do not generate as much of this greenhouse gas have relatively less political power to make a difference. So there's a difference in inequality in power. Um, and like with another example is COVID was something that could be anticipated and was avoidable, given appropriate planning. And it's the same with climate change. So we have a delayed response in responding to COVID that probably produced quite a few unnecessary deaths. And the same is happening and will be happening with climate change. And and then there's a lot of problems with disinformation. With COVID-19, we saw many examples of disinformation, lack of information, people not being aware of where to find reliable information. We see the same thing happening with climate change. And all of this leads into this sense of mistrust of expertise, mistrust of science, mistrust of healthcare providers. And that is in turn leading to many of the problems that we're facing now in terms of trying to rally around solving some of these problems.
One of the things, Mark, I was aware of just because of my background in health information technology is during the leading up to the pandemic, we believed, kind of speaking for the healthcare community, I guess, we believe that our health information systems, electronic systems, could generate information that could go to healthcare policymakers on who had tested positive, what the
Mhm.
state of the COVID ripped through this country. Not even talking about the rest of the world, but it ripped through this country. And we didn't, there was no way to really know who had tested positive and
Yeah,
who hadn't. There was no centralized thing for that, or even when the immunizations took place. But uh, the data was just so fuzzy. We thought the electronic technology plumbing was in place, that all this reporting would flow up to the policymakers, but it didn't. It really didn't.
exactly. And I think that's more and more of a problem that we're having as we're developing these more sophisticated electronic systems. We're collecting huge amounts of data. I see this more and more where we're being hit with a tsunami of data. We're overwhelmed with all the data. It's getting to be difficult knowing where the data are and how they should be looked at. And that isn't the COVID is a perfect example. EMR systems and syndromic surveillance, for example, through emergency rooms around the country. It was very useful in defining or identifying potential COVID cases, but that information was being collected at individual hospitals, perhaps uh, uh, also accumulated in health information systems, such as the health information exchanges, or as reportable diseases in state departments of health. But these are all very siloed data
Yep.
organizations, and
Hmm.
we still don't have that ability nationwide to share data easily. And that's a
Well,
huge problem.
and kind of in the crisis of the pandemic, when many folks are being tested, of course, if once we had the home test, nobody was collecting that data. But before we had the home test, if you went to a healthcare clinic, or the tents were set up to test people. If they tested positive,
Mhm.
the demographic information that was captured for that positive case of COVID was all over the map.
Mhm.
Sometimes ethnic and racial groups were identified in the demographics. A lot of times they weren't. So there was a real opportunity that was lost there. We just really weren't ready for it.
Yes, and then getting back to the idea of mistrust, there are even individuals who are undergoing testing who didn't even want to reveal that kind of information,
Right.
uh,
Yeah.
wondering how it would be used.
Yeah.
And so that's another issue.
Well, absolutely. Let me say to our audience, if you're just joining us, I'm Jim Tate. And on this special episode of the Tate Chronicles, I'm speaking with Dr. Mark Massing. Well, we've talked about kind of what some of the problems are. Hopefully, we can touch, Mark, on some of the solutions. And, in
Mhm.
the last 5 or 10 years, we hear more about collecting information about social determinants of health.
Right.
Uh, and so, speak about that. What are these social determinants of health, and why is it important to know that about an individual?
Great question, Jim. You're going to make me talk about a long story in a short period of time, so I'll
Yes,
try to be
yes, I am. Okay,
I try to be brief on that. But
okay.
actually, it's been known for for hundreds of years, if not longer, that social conditions and economic conditions influence health, and that the relationships between those conditions and health have changed over time. And in the United States and throughout Europe, there's a lot of evidence that show these relationships. So more recently, especially with the advent of electronic health records, we have the opportunity to start collecting information about these social conditions, conditions that patients experience in their communities and in their families, that are not necessarily something that they would come to
Mm,
the office and during a medical encounter and report. So there's a lot of instruments that have been developed and implemented into electronic health records that are essentially surveys or questionnaires that patients complete when they are seen during an encounter, and and there are a lot of standard determinants of health now that are being asked. For example, potential exposure to violence,
mm,
questions about exposure to illicit drug use, issues about where you live, whether you feel safe,
sure.
and that sort of thing. And these are being expanded now to take into account what's coming in the future, and the big future challenges that we will have will be really related to climate change and impacts on climate change. And so there is a lot of discussions now about what metrics should be assessed as another social determinant of health related to climate change. For example, you might ask, does the patient's house have a working air conditioning system?
Mm,
Can they afford electrical power? These are a couple of questions that might have a big impact as the earth warms and we have more and more heat waves. Um, so the social determinants of health are sort of standardized questions that are constantly under revision and they will be and are currently implemented in most electronic health records.
One of the most common ones that a question doesn't even have to be asked is, what is a patient's zip code? If you know somebody's zip code, it is very easy to determine the frequency of various, whether it's diabetes or heart disease or morbid obesity. Certain zip codes are very clearly are identified with certain health conditions. Don't know about this. Something else, we only have about 5 or 6 more minutes here. Now, I'm going to touch on a couple of things, Mark, is clinical support rules. EHRs have these clinical support rules that are based on they're either evidence-based, based on a patient's specific health record, or we're starting to see some that are AI-based, predictive-based clinical decision support rules. And I really haven't seen, there is an attempt that these AI-based clinical support rules are based on a wide demographic reach to make sure it's not just based on, well, that's the thing with a lot of AI is if it's using the internet and looking for health information, it's based on people who have insurance and went to a doctor. So
Right.
you're usually not included in these algorithms. So I hope that AI at some point is going to start being, I guess, more equitably directed to include these social determinants of health.
Yes, I think that's AI is a whole nother animal that you brought up, and I'm glad you did. And AI is such a huge, broad category. It's hard to know what people really mean when they use that term. But I think a lot of people associate it with these large language models like ChatGPT. And of course, those models are built based upon data that comes mostly directly from the internet and from other databases that are publicly available. They are input data, if you will, to these models. And so the model output is just as good as the input. And the question is, what kind of biases do we have on the input that might drive faulty results, or looking at the output from those models? As they say in computing, we say garbage in, garbage out. So if we don't trust the data that's going in, or if we don't understand it, then the results we see from AI will have to be viewed very carefully and with suspicion. So that's a major challenge, is the quality of the data and the biases of the data. And so it makes us think that we're not really ready to turn over big healthcare decisions to AI quite at this point.
Right. Well, and a final question for you, Mark. We know that this inequity and marginalized communities, we can't wave a wand, make it all go away. So as of today, what's the role of providers? Can they integrate social and justice and equity into their clinical practice? How do they do it?
Absolutely. I think I have great sympathy for providers because I know they're all very busy and they're wrapped up in what's going on in their practice. But one of the things that I really highly advise is to really get to know the communities from where your patients originate, and not only know the neighborhoods and the communities, but know how the people think, know what their customs are, and the better you can understand where the people are actually living and where they're coming from, the better you'll be able to communicate with them when they come into your office. A lot of people now are increasingly using the community health worker as an aid for outreach to patients. And that is really a great resource if you could do it, because community health workers typically originate from the communities that they serve. So they understand the communities very well, and they're a great liaison between the physician and the patient and the communities. And so I think those are just a couple of recommendations. I could go on, but I'm not sure how much time you have.
Right. Well, one final question.
Sure.
Our listeners who might want to reach out to you to discuss these things with you, or hear about some of the projects you're involved with, what's the best way to get in contact with you, Mark?
Sure. Well, I'd love to speak with anybody who has an interest, especially right now in the climate change area or working with communities around community health. So my email address for those who'd like to contact me is M as in Mark, W as in Wayne, and M as in Massing is MW Massing, MWMASSING, G is in golf, at gmail.com.
Okay, mwmassing@gmail.com. Well,
Right.
to our audience, thanks for again joining me in this episode of the Tate Chronicles. I offer a special salute to my guest today, Dr. Mark Massing. Mark, thanks for joining.
Thanks so much, Jim, and thank all of you out there for the great work you're doing.
You can find more information on this show's program page at healthcarenowradio.com. That's healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.